Welcome to Medical Myths, Legends, and Fairy Tales. I'm your host, Dr. Alan Christianson. Look, you know that between the latest online fads and the crazy media headlines, it's easier than ever to get confused about your health. And you and I just want to feel better and live longer. We want to know what works. And we can't wait for further studies. We need to make decisions today based on the best evidence we've got. Well, that's exactly what this show is here for. So let's get to it. Would you believe that we don't know the cause of most back pain? You would think it would be the herniation or the compressed nerve or the other types of damage that can show up, but those things actually don't explain it. Chronic pain is a fair amount of a mystery, and sadly, a lot of folks, the treatment they get does not align with the things that we do know, and it's often based upon myths or misinformation. That's why I'm really excited to bring Dr. Sheetal DeCaria with you today. She's a friend. She's the author of a new book called Break the Chronic Pain Cycle. Dr. Sheetal's a double board certified physician in anesthesia and pain management. She's also deeply trained in integrative medicine, nutritional care, mind-body approaches, and I don't know of anyone else that has that same subset of knowledge and specialties. We had a really good talk about just the enigma of chronic pain. The cool thing is there really are answers. There are things that can help, but thankfully, they're not invasive things, but they're more powerful than you might expect, and they're often not from the areas one would anticipate. So please enjoy my discussion with Dr. Sheetal. Okay, welcome back to Medical Myths, Legends, and Fairy Tales, and I'm joined by Dr. DeCaria. Hey, Sheetal, so good to see you today.
Yeah, thanks for having me.
So I'm excited about this topic. This is something that you probably got some good numbers top of mind, but this is always one of the top medical concerns for people, pain and chronic pain. And the story is just so much deeper than we often think.
It really is. And, there's just so many people suffering from it that don't have answers. And that's what makes it so complex in treating it.
And I saw your story that your father treated pain as well. And was there a bit of a process in terms of this being the direction for you, or how did that play out?
Yeah, my dad was an anesthesiologist and a pain physician as well. So I did have exposure to that, throughout college, throughout medical school. When I got to med school, I liked everything, but I didn't love really anything. And I kept kind of going back to my experiences in my dad's clinic because I really felt like, and of course, I may have only seen the really great success stories when I went in with him, but I felt like it really embodied what I wanted to do as a doctor, which was, help people, heal people. And it was so fulfilling to see him give people their lives back. And I was like, well, this is easy. This is definitely what I want to do.
Do you think things have changed in the last several decades as far as the typical presentation or the concerns around pain, or any of the differences from what you saw when you were with him? Or
I do think so. I think that for one thing, we're seeing rising numbers. We're also seeing rising other reasons for pain other than like physical and structural things we used to think of as causing pain. And so it's become something that has become a chronic disease and something that we really need to look at from multiple areas. And so I've seen the practice of medicine now specifically in how it treats pain try to focus more on multimodal approaches, involving psychology and physical therapy and acupuncture and all these different things, but it's still very disjointed. So although I've seen us move towards understanding pain a little bit better, there's still so many questions that are unanswered. And now that I practice it myself, I see the limitations of our system. I see how many people are still suffering, and that the need is there to really figure out a system that people can use to heal their pain and to get better and to really just understand what's happening.
And the core myth I wanted to talk through with you is something that seems so intuitive. If something hurts, it seems like there's got to be a thing there, like a thing that's broken or stuck or doesn't belong, or a foreign body. Like there's got to be a thing somewhere that you can just change and it'll be okay. But pain is not always like that, huh?
No, and that's what I think a lot of people don't understand. So I just want to take a moment to kind of go over how pain is processed in our body, because I think that'll really help listeners understand why pain is so complicated. So when we injure our finger, let's say, like you were just talking about, we imagine that there should be a pain receptor there, but the actuality is we don't have pain receptors. What we have are things called nociceptors. Now, these are receptors that detect extreme changes in things like pressure, temperature, maybe you're exposed to chemicals. And what it does is it sends a signal through your spinal cord to your brain, and then it's processed. And it doesn't just go to like a part of your brain that is for your finger, for example. It actually goes to the frontal part of your brain that is involved in executive function, thinking. It then goes to the limbic part of your brain, which is our emotional center. And finally, it does end up at a place where your brain decides whether it's going to feel pain in that area. So the part of the brain that, represents that finger. But because there's so many other pathways involved, it actually is an emotional and a sensory experience about whether your body and your brain is going to decide that what just happened to you is going to be taken as a painful experience or not.
And I guess the difficulty is that there are certainly circumstances in which it can be quite that simple. You can whack your thumb with a hammer, and that's what it was, and that was the whole
Yep.
problem. And assuming you don't do that again, it'll get better. But it doesn't really fit our intuitions quite often.
Right. And actually, it's there was a case that was actually published in the British Journal of Medicine, and this was a while back, I think 1997, where an otherwise totally healthy 29-year-old guy who worked in a construction site got a big 7-centimeter needle into his boot, or
Ooh.
sorry, a nail into his boot, and he ended up being in excruciating pain, collapsed as soon as it happened. They took him to the emergency room. None of the doctors were able to even manipulate this nail without him being in excruciating pain. So they had to sedate him. And when they finally went to go take that nail out of his foot, they found that it actually hadn't even caused any tissue trauma. It had actually passed between his toes.
Wow.
And, they went back and they were thinking, okay, this guy has no psychological history. He felt like it was really pain, and he felt that, he
Wow.
couldn't move. And part of that was that his body, his brain had decided to protect itself. And so when that happened, the brain was telling his body, don't let anyone touch it. Don't move that foot because you're in excruciating pain, and that will allow you to protect yourself. And so, we really, there's so many cultural influences and past experiences and emotions around when something happens that play into whether your body is going to decide that at that moment, that is something painful or not.
A tricky thing too is that I think that culturally, people can feel that if you entertain the idea that there's more to it than just a nail in the flesh, like in that case, it sounded like it was going between the toes, not like in the
Right.
actual foot, but to entertain the idea that there's more than just something physical there, some come off as you're diminishing the seriousness of their experience. Like, oh no, this is what I experience is real. And that
Right.
can be a bit of a disconnect. I think I've been aware of the work of like Dr. Sarno, who talked about a lot of back pain having some element of psychological stressors involved with that. And I can think of many times in which I've tried to have a conversation with people with back pain just to entertain that idea, and having it go very badly, and just really
Yes.
having them, think, oh no, as if I weren't considering their pain as being a real thing. So yeah, what are your thoughts on like our cultural receptivity to a broader discussion of pain?
Yeah, so I have this conversation with people a lot, and I agree with you that sometimes Dr. Sarno's, at least the way it was described in some of his literature, it seems like it should be an easy like switch where you tell someone, oh, it's actually nothing physical, it's in your brain, feel better. And it what I found in treating so many patients in pain is that it it is way more complicated than that. The stress itself, the constant stress, or like a severe emotional trauma, like a childhood trauma, these things imprint themselves on our amygdala, which is that emotional center in our brain. The continuous stress levels lead to hormone dysregulation, and our body's ability to, come out of that fight or flight response gets impaired. That all causes low levels of inflammation and body chemical changes that actually do cause real pain. The thing that I tell people is that it's not that your pain is not real or not physical. You are feeling it, but what it is it's tied to that emotional part of the experience. It's tied to that stress, and that you can actually heal the physical part if you address that mental and that stress component appropriately. But it is something that is felt. Your brain is telling your body there's pain there. It just may not be tied to a structural thing. Like you may not have pain in your back from a herniated disc, necessarily. And so I think it's a conversation that takes a little bit longer to explain, but and it is, there needs to be some validation to the patient that, your pain is real, because it is. And I think that's where sometimes it becomes, tricky when you approach things like this.
And so help me again, the high level categorization of pain patterns. What are the main ways we think about pain manifesting and playing out?
Yeah. So, my book goes through kind of what I think are three big categories of pain. So, and the interesting thing about chronic pain is that I see so much overlap, especially in people that have had pain for many months. I eventually see that they have pain from all of these components. So there is physical pain, they're like a structural issue, something structurally wrong. A lot of the time, this type of pain is acute pain, meaning it's less than 3 months, because usually tissues heal within 3 months. But there's some instances where like an imbalance, let's say, or like advanced osteoarthritis of a joint can continue to cause like ongoing pain that's physical. Other two categories that I think are really large in terms of, kind of compartmentalizing pain is what we just talked about. So kind of Dr. Sarno's work with that mind body tied to stress, emotional experiences in the past, maybe post-traumatic stress disorder, these kind of things causing another category of pain that needs to be addressed differently, as you can imagine, than the physical pain. And then the third is what I think is the most complicated, and it's something called centralized pain. So what can happen in certain individuals, and again, tied sometimes with, it may start with an emotional event or a physical stressor or injury. But in some people, their nervous systems actually get revved up and turned on into a hyper excitable state where their nerves get more sensitized, their nervous system gets more sensitized, and things that shouldn't cause pain are causing pain in those individuals. So things like fibromyalgia, migraine headaches, these things don't have anything structurally wrong, and that's very hard for patients. Like they may go to doctors and get tests and everything's coming back normal, but they have a lot of pain sensitivity, and little things that may not cause pain in one person will cause pain in people that have central sensitization.
Okay, so these big categories. And
Mhm.
I highly want to recommend, you got a new book, the Break the Chronic Pain Cycle, and thank you for sharing a copy with me. But
Of
I've been
course.
really, it's opened my eyes so much about this. And I think about all the people that just struggle. High level, what are some of the clues someone could think about that could make them think that they should investigate this more deeply, that just common approaches for acute pain might not be enough for them? Who is this really for?
Yeah. So to be honest, I think when we get to the point of chronic pain, meaning you've had pain for 3 months, there's a lot of other factors playing in. It's now become a chronic disease because, like I said earlier, your tissues should have healed at this point. If you're still having pain at that 3-month mark, it's important to investigate further with a doctor, look at things like lifestyle, stress, sleep, your diet, nutrition, all these other things that can play a part. If you're someone who has had, high levels of stress, emotional traumas in your past, gone through a recent, very stressful life event, or you have those conditions I mentioned that talk about where, you go to the doctor and things aren't necessarily adding up. Maybe your MRI doesn't look as bad as what your pain feels like, and things like that. People like that need to really try to investigate further with integrative medicine, thinking beyond the structural things to what do I need to do to try to heal? Because if you don't treat pain soon, this pain cycle just gets worse. And these pathways that your brain has now learned become even harder to break. And that's a big thing because, it's almost like well-worn pathways, and you can create new ones, but it's a lot easier to do earlier in the pain cycle than it is, after you've been living with pain for 20 years.
Okay. So easy rule of thumb, something's been hurting for more than 3 months should be given
Yes.
a deeper investigation. And I wonder too, you said that we're making some advancements in how we treat this overall, somewhat slow coming. I've seen many studies about placebo surgeries or sham surgeries. And it's
Mhm.
really to your point about how much is going on. That is more part of the expectation, the outcome. Anything you want to mention about that or?
Yeah, so I do go into this also in the book. It's interesting because there's certain conditions, and specifically when we're talking about specific surgeries, we talk about knee arthroscopies, shoulder arthroscopies, back surgeries. They've done large studies now where they've looked at people who've had, let's say, a meniscal tear, or labrum tear, herniated discs, whatever, and they've split them into people who do simply physical therapy, conservative management versus people who do surgical outcome or surgical interventions, and found, long term, like 12 months, 18 months later, there's no difference. And this is being repeated in specifically those types of surgeries, especially that I mentioned. And so it makes you wonder, was the surgery helpful, or was the surgery almost like a placebo effect, meaning that you do, and Dr. Sarno talks about this, that um, pain is very amenable to placebos, meaning that if someone thinks that they are getting a treatment that's going to help them, again, that brain will decide that it's going to feel better. And so that's what happens sometimes, they think, with these surgeries, where it actually, maybe the issue wasn't structural to begin with. Maybe what was found on the x-ray or the MRI was not causing the pain, but you underwent something, and that procedure made you feel better, and that lasts for a period of time, and then the pain kind of returns. And then the other thing that I talk about in the book is that sometimes the issue that you had the surgery for is a symptom of another condition. So let's say you had a weak core, weak gluteal muscles, or something that's causing these disc bulges or causing this knee pain or shoulder pain. And if you don't correct that, the surgery may help fix that disc, but 6 or 12 months later, it may re-herniate, or it may bulge out again, or you may re-injure your shoulder because you've continued those same weaknesses and imbalances that you had before the surgery. So it's hard to say with certainty, which one is 100% true, but I know that I've all of it. I've seen people who've had surgeries maybe they didn't need. I've seen people who've had surgeries that they did need, and they got better. But then 12 months later, the same issue happens maybe at another lumbar level of their back, and they're back to suffering. So it's really important with pain that you figure out what caused that issue. If it is structural, why did it happen? Why did you herniate that disc? What's wrong with your physical, body at that time that led to it?
And to the point about just the rate of change in medicine, I'd seen papers arguing that, some of these studies were quite elaborate. They would do sham surgeries. People would be
Yes.
anesthetized for the same amount of time. They would have like the appearance of a surgery taking place. They would be given some sutures. It was like all the same choreography. And the papers were pretty clear as far as the outcome, the rest, the physical therapy, the expectation. These were bigger factors than what went on inside the joint for the outcome.
Right.
Yet the rate of the procedures haven't changed since then. I mean, is
Right.
is that a fair assessment of the state of affairs?
That's what I see as well. Yes. And I think, again, it's kind of the limitations of our system. I think people want an answer, people want a solution. And if they're given a solution, and even if they're given a solution with like a 50-50 chance, it may help, it may not, I think people would rather sometimes go with that because they want to believe that it will help. And other times, I think, like I said, we kind of are missing the underlying root cause. And that's, it takes time to figure that out. And oftentimes those things aren't really looked into before surgery. So those are opportunities we're missing.
In a bizarre additional level I've thought about this with is I've had a lot of orthopedic surgeries myself. And I wonder if some of them perhaps would have been similar placebo responses. But then I thought, but would I have taken the downtime, and would I have done the physical therapy, and would I have done all those steps if I didn't think I had to because I just did a surgery?
Right.
So maybe it still was necessary, but not for the reasons I thought.
That's one way of looking at it too. That's funny.
So when you hear from people that they come and they reach out for your guidance, they've struggled with pain for some time, is there, it's like one, and I'm sure many are at different levels of complexity of their own efforts. And there's some that are probably rather new to things, but I would guess that many that come to see you have already tried a lot of steps before they've gotten to your doorstep. They've already gone through many other things. So when someone comes in and they said, hey, I've tried it all. I've thought about things from all these ways. I eat well, I've done rehab, but I've still got this. Is there like one or two things that people just don't think about that are common, really big denominators? In your mind, you're thinking, oh, I bet they didn't do X, right? I bet they didn't think Y. Are there recurrent things that come up like that? Or is it just like always different? Or what do you think?
So if I were to pick just a few things, the one thing I would say that I really notice a lot of, I mean, this even applies to patients that have gone through physical therapy and things like that. People are missing looking at the whole picture, and I think that's a limitation again of kind of our system sometimes. So if someone comes in with foot pain or knee pain, a lot of times everything has been focused just on that area, and they've done physical therapy for the knee, they've done exercises for the knee. The problem may be actually higher up. So it may be in the hip, it may be in their pelvis and how it's tilted. And I especially see this a lot. I treat a lot of women. So I see this a lot with women, where either childbirth or just the way, our anatomy is, there's a lot of issues that are actually higher up in the pelvis and the hip that lead to pain lower down. So maybe in the knee, maybe in the ankle, maybe in the foot. And what I find is that sometimes, like I said, it just seems like we're pinholed. We're looking at one area, missing this whole picture that everything is connected, everything's a chain. And so, yes, maybe you've done physical therapy, but maybe you need to actually have a whole, kind of evaluation of your whole body to figure out exactly where the pain may be coming from, because the source may actually be somewhere else that isn't having pain. But that area is actually causing the structural problems that's leading to pain, further down the line of the chain. So that's one thing. And then the other thing that I see a lot of is that I think, at least I have a hard time sometimes talking to patients about this, is the impact of nutrition on pain. And I think that, it's not just kind of eating healthy. People do try to eat healthy and everything, but everyone's definition of what that is different. There's a million diets out there. But the impact of specific foods, low-grade inflammation, these kind of things on pain, and especially like certain conditions that really respond well to changing diet, things like migraines, fibromyalgia, for example, is another one. So I think sometimes that's something that's never been introduced to patients when they walk in the door. They may have seen 15 specialists and a surgeon and all this other stuff, and had a million studies, but no one has ever mentioned the importance of what they're actually eating as causing pain. Because again, it's a totally different area. So everyone's focused on a specific physical area and missing that maybe it's actually related to what they're eating.
What are a couple of the most high value dietary changes you think are useful for some of those central pain patterns?
Yeah, so there's been a number of studies that have looked at various, specific diets, but what I've seen, the larger review studies looking at 300, 400 studies that have really pointed towards things like the Mediterranean diet and anti-inflammatory diet as being the most kind of beneficial, and really just simple categories of things like eliminating those processed and packaged foods, a diet that's mostly plants. There's been a lot of studies on vegan diets, especially for different kinds of inflammatory conditions, autoimmune conditions. But, really just trying to eat more plants, less processed foods. If you are eating meat, not a lot. There's diets showing, red meat's not great for pain. And really trying to eat herbs, spices, just nuts, healthy fats, really just trying to eliminate like the standard American diet, unfortunately.
For to you and to the listeners, I just want to highlight something about the thought process you were demonstrating. So one of the ways we get a lot of confusion and conflicting dietary ideas is that they're so often based upon seemingly simple rules or models, like a diet is bad because of this thing or because of this particular chemical pathway. And I love how Sheetal didn't mention that at all. It was just, here's what we see from outcomes. Here's empirical data from real world humans and what's happened. And when you look at things from that level, a lot of conflicts and confusions just seem to vanish. But if you try to base things on simple mechanisms or chemical pathways, or this is the most important thing, or this particular nutrient or this particular anti-nutrient, then there's so many ways you could make predictions. And any one of them could be a great thing on which to base a hypothesis that you could do studies off of, but they're just not good things to base conclusions off of. So please, when you hear people talking, listen to languaging like Sheetal uses about, here's what we see from studies, not like, here's the model, here's a reason, but here's what's happened to people.
Right. And I always, kind of tell people that try this first before picking up the latest supplement that you may have heard may help your condition. And there are additional testing and things like that, and there's specific diets for specific conditions, but this really applies to a lot of inflammatory conditions, including heart disease, diabetes, pain, all these things, that if you can at least adopt a diet like this, see what happens to your symptoms. Sometimes that's enough to really reduce your pain. And then in others, I go through elimination diets a lot, because I think, sometimes people may not realize that they have a food sensitivity. And really the best way, like, yes, you can test for food sensitivity, but I always find that, again, clinically, you need to look at what happens to that person when they eliminate that food. And I've really gotten some great results with doing elimination diets and being able to pinpoint specific things that cause issues in specific people. And I mean, the same thing happened to me. That's even how I kind of got into this integrative world, was I did my own elimination diet when my second baby was born. And I had never had problems with dairy before in my life, but apparently it was causing my foot pain that I had dealt with for 4 years.
Wow.
Yeah.
One more thing I'd love to have you talk to people about is we really get frightened about physical activity and exercise. And there's been many who have written about like the dangers of chronic cardio and the issues of overtraining. And I'm sure that that's possible, and then even in the realm of pain, there's a lot of thought that if you keep on moving, you're going to wear that out. You're going to burn through your joints. What are your thoughts with the relationship to exercise and those that are in chronic pain?
Yeah. So, I'll start with just talking about back pain when it comes to that, because back pain is like the number one thing that people go to their doctor with, and so many people have it. We used to, long time ago, people used to say, you needed to rest, for example. And now the recommendations are completely opposite. There are some conditions in which you want to limit your activity. And so I always tell people, if you're having severe pain, especially acute new pain, go see your doctor, make sure it's not something that requires you to not move. But the things that require no exercise are very small in number. And the majority of the time, actually, I think 85% of the time when we're looking at back pain, a study in the Spine Journal said that 85% of the time, people don't have anything structural, meaning that
Wow.
that back pain is not a herniated disc, it's not a fracture, it's not cancer, it's not spinal stenosis, it's non-specific, meaning it's muscles and ligaments. That pain does not get better with rest. And that goes for a lot of things, like even arthritis and everything. If you get stronger, your pain is going to improve. And so if you're deconditioned, if you haven't been exercising a lot, I don't recommend you just go out and start doing even yoga without any training. But getting an evaluation with a physical therapist is going to be huge for people that maybe are not super active. And then for people that are active and, let's say, have an episode of back pain that's found to be, like I said, a non-specific, non-structural back pain, the recommendations are you will get better the more that you actually move. And so, this goes for even those severe bone-on-bone arthritis. If you strengthen everything around that joint and then have your surgery, or even before you have the surgery, you might find that when you are, better able to balance your own body, you're not straining that joint as much, you're not having as much pain. So there's really few times that I'm telling patients not to exercise, because the data just shows that, movement is good. And even walking, anything that you can do safely is going to help.
And that's awesome. And I hear many that think about their own issues with their thyroid health or their other hormonal stressors. And yeah, they hear well-intended messages and discourage them from being active, as if they're, there's this idea about, I've heard someone summarize the idea as that which doesn't kill us makes us weaker. There's a poisonous, pervasive thought that we are just fragile and we will collapse. And I've heard the concept described as antifragile, that no, we rebound. I mean, of course, things could be excessive and inappropriate, and that's different. But with the right amounts of appropriate stressors, we come back better from that. But we have to
Yes.
endure that.
Yes, exactly. And I think also what happens is like a fear develops around a label. And I've seen that a lot with labeling with chronic pain, where you get that MRI, you get that X-ray, and now you have a label. You have something that showed up on there, degenerative disc disease. And so, any type of pain you feel in your back, you're going to say, oh, it's my degenerative disc disease, when in reality, it probably has absolutely nothing to do with that, because the studies show a lot of times that a lot of these things we're seeing on these MRI studies do not cause pain. They're found in people that have no pain. They're found in normal aging. That goes for even labrum, tears of the shoulder, rotator cuff tears. I think one study actually looked at Major League Baseball players and found 50% of them with no shoulder pain have labrum and rotator cuff tears.
Wow.
And I think they were full thickness tears too, so not small ones.
Wow.
Yeah.
I want
Yeah. And
to,
again, oh, sorry, go
I
ahead.
was going to say, I just want to expand on that. So go ahead. I think you were about to do so yourself.
Yeah, it is really important that people realize that, because even so, let's just take, the back, for example. So MRIs, they've done studies in the Spine Journal that have looked at asymptomatic people, so people that have no pain, and found that 52% have at least one disc bulge.
Is
And this
that
is,
with a certain
no pain.
age adults or?
Yes. Oh, I'm sorry. It's usually between age 60 and up. So, 30 to 40-year-olds, it's a lower percentage, but I think 30%, something like that. So they still can have a disc bulge as well, not causing symptoms. But as you're getting up to like 80 years old, there's a long list of age-related changes that you'll see on your MRI, on your X-ray, that are not, that are not necessarily tied to pain, because they're seeing all those same findings in individuals that have no pain.
But I'm sure I'm older than you, but even like, younger adults, there's a pretty good chance you could take someone our age, me being older, and just do a film and find things wrong, and
Yes,
that's the
absolutely.
tricky part, because if someone has something hurts and they get imaging done, the doctor looks at that and, oh yeah, your back hurts. Well, you've got this thing right there in your back. It seems like just a closed case that's got to be the problem.
Exactly. Yep. And that's why, a lot of times when we are relying so heavily on these diagnostic studies, we are missing a huge portion of what actually may be causing your pain. A big part of what I do is just a physical exam, to see if it actually correlates, because a lot of times people think it's coming from that, and it may be a pain in a completely different area that has absolutely nothing to do with that. So as an interventional pain doctor, part of what I do is actually, sometimes we do injections to help with diagnosing as well as treating pain. So when I inject something, I'm using X-ray or ultrasound that allows me to take a picture of an area. And then I put numbing medicine along with sometimes a cortisone or an anti-inflammatory steroid. But that numbing medicine component is really important, because if you're numbing up a joint, let's say, or an area of the back or a nerve, the pain should go away if that is the source of your pain. And so part of what I like to do is use procedures to diagnose and, investigate whether their pain really is coming from that area or not.
Could there be patterns to where there is a lot of complex pain that's multifactorial, that there's still some decrease with local anesthesia, even if there were other factors driving it?
Yes, absolutely. So again, with back pain, it's very complicated. There's a lot of structures back there that could be causing it. So I do see sometimes it's the spine, but it's also the sacroiliac joint, which is an area outside of the spine. Sometimes there's also additional muscle spasms. So it does become a little bit tricky. What helps is kind of gauging the percentage relief that they have, but also the duration. So I know what type of numbing medicine I gave.
Got it.
And,
How
I
long
can
it
find out
lasts.
right. So when we call them the next day and it's we ask the question, well, how long did the relief last? That we can kind of gauge, was it placebo or did they really have relief, and what percentage, was it 50% of your pain or was it 100% of your pain? If it's 50%, then we're looking at, like you said, other areas that may be causing it. But again, it is really hard. It's hard to treat pain because there is that placebo effect. There is just so many things in one area that can play a part. And so, it does take a little bit of digging sometimes to kind of get to the root of completely eliminating someone's pain.
I just mentioned specifically, because I hear this so much from my readers. So if you're listening and you've had chronic back pain, maybe you had an MRI. People often have, and maybe you've got some lesions, some degeneration, some herniation, and those things are really there. People are often in a place where they feel like they have the option of just having the pain go on, or attempt some procedure, which might be invasive, might be ill-advised, and perhaps they're wary of, and they often feel like that's what they're stuck between. But what I want you to hear is that even if there are lesions there, they may not be the sole cause of the pain. And even if they're contributors, there are many things you can do to make a big difference about that. So something I love about the book too is that there's great discussions of these topics like we're having now in much more detail to help you understand that. but it's a 90-day program too. So you're walking someone through a whole process that by itself can make a big difference. Can you just give us a highlight of what the 90 days looks like? And
Yeah, of course. So the first part is kind of what I talked about with trying to decide what type of pain you have. So you take a quiz, and then based on that, the first 45 days is actually trying to target your specific type of pain, whether it's physical, whether it's the mind-body syndrome. So there's, laid out plans for each of those because that treatment is different based on what kind of pain you have. And like I said at the beginning, you may have all three, in which case, you have to kind of work simultaneously at the different things. And then the second half applies to really everyone with chronic pain because it's addressing all the lifestyle factors that do play a part. And it may not be the whole picture, but nutrition does play a part in nearly everybody to some degree. And it goes over things like that. It goes over things like what exercises should you be doing to avoid the most common physical pain conditions? What are great dietary habits you should go through or implement? What are some environmental toxins that may be kind of adding to your overall toxic burden that may be causing some fatigue or some headaches or other issues? And so that's the second 45 days, which is really going through not just eliminating the pain that you have, but also what you should do moving forward to try to prevent future pain issues. Because that's a big thing too, is that yes, we want to make everybody feel better now, but I hear it all the time where people say to me, I wish I'd met you X years ago. I wish I'd met you when this pain first started. I wish I knew this 10 years ago when I could have started doing this stuff back then and not be getting this surgery now. So I'm hoping that the book reaches people that maybe don't even have that much pain yet, but are able to prevent developing really severe pain down the road.
so if something's been lasting more than 3 months, it's time to really think about that. And this is a tough one. One last thing, I'd love to just give you some insights on what our average prognosis could be. Everyone's going to be in different situations, tons of different combinations and durations. But yeah, the average person with chronic pain is it realistic for them to think that they've got some degree of improvement that's available to them?
Absolutely. Yes. And I do think that based on how long they've been in pain, that plays a factor into how easy it is to kind of break that. They may have sort of smaller milestones initially, and it may take a lot longer. There are some people that we may never get to 100% relief, but for many people, if you get to 70, 80%, that is significant. I mean, if that pain is not the predominant thing you're thinking about day to day, it really improves your quality of life. And I find that once people start to feel even 40% or 50% better, they just have that extra boost of, energy, and their mood improves, their relationships improve, and then they kind of continue to move forward. So I do think that pain that's been around for a long period of time, centralized pain, for example, these ones they're harder to treat, and that it's okay to investigate holistic and integrative therapies and mix those with conventional therapies. Some people may need medications, you may need those surgeries, you may need those injections, but if you're doing these things with it, you are going to have a much higher success rate of having long-term pain relief and also just more pain relief in the short term too.
That's awesome. And I'd like your feedback on this last idea. So I've come to think that you can think about your health on a continuum, and whether that's your pain level, your energy, your performance, whatever it is, you can put this on a continuum to where you've got something that's perfect, something that's like just maybe you're dead, like the worst possible, whatever it is. And there's wherever you are. And I've come to think that I don't think your experience is as much where you are in the continuum as it is which way you're moving on the continuum.
Yes.
If that makes sense.
Totally
yeah.
agree.
So even if you had some difficult issue, if you can feel some progress, if you can feel it's moving the right way, it's not like only you hit here, now you're better. No, the moment you start making some progress, that's the new experience. That's where you're feeling better.
Yes, absolutely. And the thing is, certain people, like especially fibromyalgia just keeps coming to my mind because these patients are told you have this condition, there's no treatment, there's no surgery, there's medications may work, but you're going to live with this for the rest of your life. And you're going to be in excruciating amounts of pain. How is anyone going to feel when you hear that? You're going to feel terrible and you're going to lose hope. And I've seen a lot of fibromyalgia patients that have walked in the door feeling like this. And I've kind of broken it down for them and said, there are ways that piece by piece, we can slowly get you feeling better. And even just that idea that there's hope to get back on that spectrum and move towards relief, that alone makes them feel better. And then as they start working towards things and they're slowly moving, they realize I'm not just stuck in a lifetime of 10 out of 10 pain. They really start to improve. And it's like so gratifying to see because, when you lose hope or you think that you're not moving in the right direction, it's terrible for your health on multiple different chronic diseases. So I think part of it is like you said, just keep moving forward. Realize there's things you can do that you have control over to improve your pain, and that you don't need to rely on a surgeon to fix you or anyone else to just do something and fix you in a second. That you actually have control over taking steps, taking action to continue to move towards feeling better.
That is awesome. Great message of hope. So I think the biggest myth we can put up that we're busted is that pain is something you're stuck with. You don't have to be stuck with it. You can do better. And Dr. Sheetal has a good answer to make that possible.
Thank you.
All right. Thank you so much for joining us. And listeners, thank you for being here. And I'll see you again really soon. Take great care of yourselves. Hey, Dr. Christianson here. Thanks so much for joining me for another episode. Is there a topic you'd like me to cover? I'd love to hear from you. Just go to Dr. Alan Christianson on Facebook or Instagram, write your question, and use the hashtag #MedicalMyths. Did you find this show helpful? If so, please take a minute and leave us a rating on iTunes so that others can know. Thanks much. I'll be back with you real soon. Bye-bye.